Hello, my name is Ian McCall, and this is a short video on Lichen planus. It's from the series Dermatology for Dentists and Dental Students. Lichen planus is a condition that a dermatologist often does see, and it may well be a presenting condition to a dentist. Let me start by just emphasizing this point here. If a patient only has lichen planus in the mouth and nowhere else, then first of all consider a drug reaction. And the reason I bring that up right at the very beginning is that it's one of the few causes of lichen planus that can be cured. We really don't know the cause of lichen planus. We look at it as being an autoimmune disease, that some allergen has bound to oral mucosa, and the immune system has then reacted to it, or that there's a breakdown in the immune system itself, and the tolerance of self has gone, and the immune system attacks mucosal linings. Because lichen planus, when it does affect mucosa, can affect not only the inside of the mouth, it can affect the genital surfaces and the vulval and vaginal surfaces as well. But if a patient doesn't have any cutaneous features of lichen planus and there's only oral involvement, then look for a drug. Most cutaneous lichen planus will resolve in a couple of years, but oral lichen planus, the mean time to resolution is about 4 years. If it's a particular drug causing it, then you can resolve it by removing that drug. Now, let me just go down to the drugs, because we've got them here. The major ones to consider are the ACE inhibitors in hypertension, the beta blockers that people have when they've got heart rhythm problems, atrial fibrillation, ventricular ectopics, hydroxychloroquine for malaria, or it's used in discoid lupus, and thiazide diuretics like Moduretic or Lasix. These are diuretics used in edema. So if a patient's on ACE inhibitors, beta blockers, hydroxychloroquine, thiazide diuretics, then consider that that may be the cause of their oral lichen planus. You can see there's a few pictures we've got there. I just want to first of all say how can lichen planus present in the mouth? And there's a few terms you've got to understand. It can present in a reticular or net-like pattern, particularly on the buccal surface. It can present as an erosion on the inside of the mouth. It can present just as a red patch on the inside of the mouth, and the other name for that's an atrophic type of lichen planus. Or it can present as white plaque-like areas, like leukoplakia. So reticular, erosive, erythematous or atrophic, or white leukoplakic plaque-like areas. But the classic pattern is this reticular or net-like pattern on the buccal mucosa. But note, more than one type can be found in the same patient. Let's have a look at one of those oral. Here we go here. There's this typical net-like pattern. We'll bring these images up in a minute, but there's this typical net-like pattern, either white lines, occasionally white papules, on the buccal surface of the inside of the mouth. That's the sort of erythematous or atrophic type, but if you saw that under a dental plate, you'd be considering the erythematous type of candidiasis. This is lichen planus, by the way, on the skin. It presents as itchy purple papules, and they're typically in the dorsum of the foot like this, or on the volar surface of the wrist. And you'll sometimes get thicker areas, thicker lesions on the anterior shins as well. But just look at a patient's wrist, look at the dorsi of their feet. Now, we've said the reticular, the erosive, the erythematous or atrophic, or the white plaque-like things like leukoplakia. The most common sites, the posterior buccal mucosa, but note, these are the other sites: the gingiva, the labial mucosa, the tongue, the vermilion of the lower lip. Infrequently lesions on the palate, floor of the mouth, and upper lip. So gingiva as well. And on the gingiva, when you've got lichen planus involving that, it may present as desquamative gingivitis. Now, desquamative gingivitis a variety of inflammatory oral diseases can do this, and lichen planus is just one of them. But you can get other conditions such as pemphigus, such as mucosal pemphigoid, bullous pemphigoid, lupus. They can all give a desquamative gingivitis. The patient, may present with inflamed gingiva and bleeding from there. So we said that erythematous or atrophic lichen planus, the one we showed there on the roof of the mouth, it looks red, it's not ulcerated. And Wickham striae are these white lines that can be seen around the outside of that atrophic red area. Then erosive lichen planus, that's where you've got an erosion, loss of the mucosal surface. Now it may have started as a bulla, as a blister, that's burst and the surface sloughed off. And this can resolve with scarring. And if you've got a dark-skinned individual, they can get hyperpigmentation in the inside of the mouth. It's one of the features of lichen planus in the skin. When it heals in the skin, it'll leave a dark pigmentation in the skin. Same thing can happen there on the inside of the mouth in dark-skinned individuals. We've talked about that plaque type of lichen planus that looks like leukoplakia, white with a rough surface, maybe asymptomatic, usually buccal surface or tongue. Remember that SCC malignancy can develop in areas of chronic lichen planus. That's one other thing to remember. Someone's had lichen planus for many years with a lot of inflammation, a lot of erosions, then they can develop an SCC malignancy. So just watch for that if someone's got chronic oral lichen planus. Then there's this condition called lichenoid mucositis. This is a lichen planus-like reaction adjacent to old amalgam fillings. And if you biopsy this, it will be reported as lichen planus. Now, it's presumably some reaction to the mercury, or it's thought to be an allergic reaction to the mercury in the old amalgam fillings. They're old, and the mercury's leaching out, and it's causing lichen planus opposite that area. You've got to take them out and replace them with porcelain or composites. And we've mentioned that desquamative gingivitis variant, the atrophic or erythematous variant with bleeding gingiva, and these other diseases that can cause it. Oh, and one other thing, watch for Candida superinfection in cases of oral lichen planus. Because whenever you've got a surface that's eroded and inflamed like that, it encourages the growth of Candida. And also, some of the preparations that we use in the inside of the mouth to try and suppress the inflammation of lichen planus, with topical steroids, they can cause the growth of Candida. So, if you've got a patient with lichen planus, it doesn't matter what you're treating the lichen planus for, stick in some Milstat or some amphotericin lozenges and get them to suck those as well, because that'll get rid of the secondary Candida. And it's amazing how much secondary Candida there can be. Let's look at these images now. Let's put them in this form. We can see them easier here. Okay, those are those purple papules that you'll get in the dorsum of the foot or on the volar surface, palmar surface of the wrist in lichen planus, very itchy. This was that reticular pattern seen in about 40% of oral cases of lichen planus on the buccal mucosa. That was another example. You can see it better there. These reticulate, I saw the lines here. Sometimes little papules will be organized in that fashion as well. Now differentiate that from a buccal bite line, where you just get a white line along here where the cheek's been caught in between the molars there, but you won't get a net-like pattern like that. There's again that atrophic or erythematous type of lichen planus. But as I've said there, if you found that underneath a dental plate, then consider candidiasis as well. There's a shallow ulcer, that ulcerative type of lichen planus, with a sloughy base to it. Occasionally you can't see it here, you've just got some erythema around this, but occasionally you can get white net-like lines around there as well. There's a really severe lichen planus at the inside of the mouth. You've got erosions, you've got white plaques. There may have been little blisters here that have burst. Look at the involvement down on the lip here as well. That is a painful mouth. We can't really see the gingiva, but you can rest assured there would be an erosive gingivitis there as well. This was lichen planus in a coloured individual. You can see the pigmentation she's got from the lichen planus on her skin. That's the reticulate pattern that she's got in her buccal mucosa here, but you'll sometimes see little areas of pigmentation in here. because pigmented patients, when they get lichen planus, they get marked hyperpigmentation when it's partly resolving. There's lichen planus on the lower lip. I mean, I couldn't diagnose that definitively as lichen planus. I mean, I'd look at that and I'd say, well, is that a skin cancer? I mean, is that an SCC? Is this leukoplakia with an SCC? So I'd be biopsying that first to see what the histology shows. Discoid lupus can involve the lower lip and can look very, very much like that as well. So again, you need a biopsy to see. Take a punch biopsy. Take a 4mm punch out there, put a Vicryl suture over it. Maybe take two there. You know, if you just take biopsies of ulcerated areas, it often won't show you much. You need to take a biopsy of this area around about here to get your diagnosis. That's just another nice example of the reticulate type in the inside of the mouth. There's lichen planus affecting the tongue. Difficult to diagnose as such. You get that surface, that sort of white surface should make you think of lichen planus. The erosions in here as well. Look at that ulcer there. This will be a very painful tongue. We're looking for other features of lichen planus inside there as well. And this is the histology of lichen planus. It's an inflammatory disease. These are lymphocytes that are attacking the base of the mucosal surface. Now, admittedly, this is the skin. That's why you've got all this keratin on the outside. But you get accentuation of the granular layer here as well, that bluey layer. You get accentuation of that in lichen planus. You sometimes get a sawtoothed base to the epidermis here, you know, a sawtoothed pattern. But this is the lichenoid infiltrate of lymphocytes hard up against the base of the mucosal surface, and it's attacking the base of the mucosal surface, and that's what's causing the erosions. And if it really attacks it there, you get a blister occurring, and the whole thing sloughs off. But as I said, the lymphocytes are nibbling away at the basement, at the cells of the basement membrane here, causing the damage. So a bit of acanthosis, sometimes sawtoothed acanthosis, thickening of the granular layer, dense lichenoid infiltrate, band-like lymphocytic infiltrate, damaging the basal layers, causing vacuolar degeneration. That's the histological term that's used for the damage to the cells of this basal layer here. So that's gone through all the images for lichen planus. We had a couple of other comments down here. These were just the lichenoid drug eruptions that we were talking about already, the ACE inhibitors, the beta blockers, hydroxychloroquine, the thiazides. These were your differential diagnoses, you know, the other white patches on the inside of the mouth. We've gone through all these before in the white and red lesions, you know, leukodema on the buccal surface, leukoplakia. It might just be hyperplasia, but it might be dysplasia and developing into SCC. Candida, of course. An SCC itself presenting as a white patch with perhaps an erosion. The lichenoid drug reactions we mentioned them below. The lichenoid reaction to mercury and amalgam. Graft versus host disease. That's where someone's had a transplant. And if they start reacting again, you know, they're on drugs to try and suppress their immune system from reacting against the transplant. But if that's not working, their immune system will attack a variety of tissues in the mouth, is often involved as well. And they get a picture very like that severe lichen planus I showed you before. And then the other autoimmune blistering diseases with your desquamated gingivitis, you know, your pemphigus, mucosal pemphigoid, that's a scarring type of pemphigoid that particularly affects the mouth and the eyes, conjunctival surface of the eyes. Good old bullous pemphigoid, but it'll usually give you blisters in the flexures, first of all, before it hits the inside of the mouth. Lupus. Again, it's usually systemic lupus that's going to give you the oral involvement. And that condition, epidermolysis bullosa acquisita, it's an autoimmune disease that can affect the inside of the mouth, usually sites of trauma, but it'll affect the back of the hands and the feet as well with little blisters on a non-inflamed base. What about the treatment for lichen planus? We should have a chat about that. You know, basically, remember there's non-drug methods, first of all. Good oral hygiene. Make sure they're cleaning their teeth, looking after their teeth properly, not getting secondary infection in there. watch that you haven't got rough teeth that are rubbing or bad fillings or anything like that rubbing up against the inside of the mouth, because that damage will cause the lichen planus to start up. And, if they've got plates or other things, make sure they're not causing problems. Avoid local mouth trauma. In other words, don't bite the inside of your mouth. Or play around with your teeth, because that just encourages it as well, lichen planus as well. Stop smoking, avoid acid, salty foods, anything else, the sharp things that are going to damage the inside of the mouth. Potato crisps, that type of thing. And then the drugs. What drugs do you use for oral lichen planus? Well, you can use topical steroids. Now, it needs to be fairly strong, and usually the ointment basis, so that they'll try and stick there. But there's one called Kenalog in Orabase. Orabase is a base that sticks to the mucosal surfaces, and Kenalog is a stronger topical steroid, so you can use that. Tacrolimus is a calcineurin inhibitor. It reduces those T cells, remember those lymphocytic infiltrating lichen planus? It reduces that, and you can use tacrolimus ointment on the inside of the mouth as well. We don't have that in Australia yet. You have to get it made up. We do have Elidel, which is pimecrolimus, and it'll work, but tacrolimus is even better. You can use intralesional steroid injections. Get some Kenacortide 10, dilute it down a bit. You can inject that into areas of lichen planus to help to suppress the inflammation. You can get both topical and oral cyclosporin. Cyclosporin inhibits T cells as well. It's called Neoral. That's the oral form of it, and it's used as a second-line therapy for severe autoimmune conditions. Oral steroids are very effective in treating lichen planus. They're the best anti-inflammatories we have. But you need decent-sized doses of about 50 milligrams to start off with and try getting it down. But you can get on top of oral lichen planus using oral steroids. Retinoids are drugs that are used in acne and psoriasis, like neotigacin or tretinate. They can be used in lichen planus, but they're not often prescribed. And then you've got some of the steroid-sparing agents like Imuran, azathioprine, which can be used in a variety of autoimmune diseases, particularly pemphigoid and pemphigus, but it can be used in lichen planus as well. But you've got to watch the kidneys, you've got to watch effect on the blood as well. So, difficult condition, lichen planus. It was, by the way, we haven't chatted on whether it might be associated with hepatitis C. It's still very dubious that, but it's worthwhile checking these individuals out and make sure that they're not hep C carriers. Because if they are, then, in some parts of the world, lichen planus is associated with high levels of hep C carriage, particularly in Japan. Okay, that was probably more on lichen planus than you actually wanted. Just remember the various types. Go back up to the beginning there and remember the various types that you can get. Remember the reticular types, the most common, the erosive, the erythematous, the atrophic, and the plaque-like types. Just remember what it looks like. Remember desquamative gingivitis as a presentation. And take a punch biopsy. And remember it can affect the lips as well. And that little tip there, watch for Candida superinfection. Treat that with fungal in lozenges, amphotericin lozenges. And if a patient only has lichen planus in the mouth with no skin manifestations, then consider that it might be a drug reaction and look at that list of drugs that they might be on. There are more than these. These are the commonest. But think about drugs as a cause of their oral lichen planus. And because if you can remove a causative drug, you can fix their problem. Thanks very much.